Well, you've all scanned babies. You've all done growths, yeah?
Mm-hmm. Yeah.
Okay. So I guess it goes without saying, you know, you find the head, you make sure if you haven't seen the baby before, you know, like a situs. If we haven't seen the patient at all, we do everything. Head looks beautiful. So head up, lying breech at the moment. Beautiful heart beating away, coming down. You can just do all your normal checks. You've got stomach, fluid-filled stomach, fluid-filled bladder. We also do just have a quick look through the kidneys, both sides of course. Do diaphragm. If you can see the skin line, we try and do that at some stage as well, just looking for sacroteratomas and things that might pop up in the third trimester. So obviously we want to look at MCA, which is good to use your HD zoom. So BPD, you've got your thalamus and you've got your cadence septum and pellucidum here. You want to angle through that suture there. So if you just kind of tilt up, you should be able to pick up the MCA running. It'll pretty much run parallel with the ultrasound beam, like straight up towards the camera, and then normally it runs a little bit more anteriorly. So if you've got the folks running horizontally, you'll watch it go that way, but when you're angling through that suture, it'll come and you won't have to angle correct. So let's try and see if we can find. Okay, so here it is running anteriorly, like towards the front of baby's head, but then we want to angle through that suture and it just pretty much lines straight up, so you don't need to angle correct. Then you just pop your pulse wave Doppler on. Gate should be about 2 millimeters, and you want to aim for about 2 millimeters from where it originates. So it's a bit, sort of usually about there. Oops. So we'll just drop the PRF, make the waveform a little bit easier to see, and you should be able to get, you know, 6 to 8 cycles on the screen. You can then just use your beautiful auto trace because this baby's lovely. Takes a bit of time, I guess, to trace, but yeah, one is okay. MCA by itself doesn't really give you a lot. You could, if you've got a baby that's, you know, suspicious for anemia or somewhere where you're expecting the velocity of the blood to be higher, the MCA, you can check the PSV. But we use the MCA PI and the CPR ratio, which is the Cerebroplacental ratio, which is comparison, or we use the PI of the MCA and compare it with the PI of the umbilical artery. And that's sort of the best indicator or independent indicator that we have of fetal prognosis, or poor outcome. So basically all you have to do is take a trace of the MCA, take a trace of the umbilical artery, and then you compare the MCA, the PI rather, so the PI of the brain divided by the PI of the umbilical artery. If it's 1 or greater, that's a good thing. Because when the babies get into trouble, they sort of shunt, you know, they do that cerebral shunting, so more flow goes to the brain. So the pulsatility index of the brain drops. So then it just approaches 1 and then it goes below 1. And that's when the baby sort of is in trouble. If you're struggling to get that MCA to light up, drop your PRF And you can even change your probe. So I generally scan with the 3D with this probe, but sometimes particularly if you're doing a growth and the baby's head's wedged right down, you can use the more narrow footprint transducer and you can get underneath it for a better angle. But yeah, it's just sometimes you have to roll patient just to try and get access because it's not always going to be that beautiful. So once I've got my MCA pulsatility index and I think, oh yeah, the waveform looks good, there's not too much end diastolic flow, it doesn't look like there's any sparing. There's a neat little trick that I wasn't aware of actually, that I got from Erica's presentation on the ASA. She said that if you are, it probably pertains more to the peak systolic velocity when you're doing a baby that might have anemic changes. If you have a PSV with a mom greater than 1.5, and of course you're not going to know that until you get into your charts, that's abnormal. But a really easy way to kind of, when you're scanning, is if you double the gestational age in weeks, so say you're 25 weeks and you double that, that's 50. If the PSV is greater than that, then it sort of indicates it is most likely going to be greater than 1.5 moms. So that's abnormal. Yeah. So that's a good little trick when you're in the room.
And with that PSV, are you only doing that for the anemia?
Yeah, it's pretty much. Pretty much. You can. What is it? They've got anything that would make the velocity, the blood velocity higher. I guess it's mostly anemia. I don't think there's much else that we really see clinically to be pretty.
Peak systolic's one of those slightly forgotten about.
It is, numbers. I agree. Not
because the reasons leading to that are kind of rarer, aren't
yes,
they? Like
yeah.
Those
it's not
auto, allo, rhesus, viral. But the good thing is that our viewpoint software has the chart, so all you've got to do is get what Jasmine just got, look at the chart, and it'll tell you. Mari is the author for peak systolic velocity, and they use that for twins, and the PIs, it's all in front of you. So
now we might move to, so we got such a good MCA, although it's been a while since we took it. Hopefully Bobby's still pretty quiet. It's important to do these Dopplers when the baby's not jumping around, doing lots of breathing, hiccups. It all makes a really big difference. I actually did a growth scan today on a baby who was so active. I just literally had to sit there and wait a good 10 minutes before I could even, I'd do the MCA. It was just ridiculous. It was all over the place. So you just got to really be careful to make sure, you can see it. You're not going to get that lovely trace when umbilical artery, I guess most of you would know, you don't take it too close to the placenta. That's the low resistance end. Don't take it too close to baby's belly. That's the high resistance. You need one in the middle, a free loop, one that preferably baby isn't kicking. So I guess, you don't have to you don't really have to find where it inserts into the placenta and trace it back. You can just sort of see that this part here is sort of in the middle and should be okay. It is good, again, to try and use a piece of the a bit of the artery that's sort of 0 degrees. So I'll just pop it on. That's not going to work. What's that? That was a pain. Hang on a minute. Find the artery. And I like to have it, the waveform on top of the baseline, so I generally change it, but that's pretty nice. It's pretty lucky. You'd expect to see, the peaks of the umbilical artery to be quite all the same if you can. There's usually, so the amount of diastolic flow in the umbilical artery changes as the baby grows. So initially the waveform in the umbilical artery is quite high resistance, and that's because baby doesn't need as much flow, I guess is one word of it. But as it grows and requires more, the diastolic flow low resistance. So the waveform changes from being quite pointy to flatter. And it's pretty easy to, you can change the gate. I think you can change the gate to be more than 2 millimeters, but I just generally use 2 millimeters. Then you just choose your little umbilical artery, auto trace if you've got a lovely trace like that. As soon as I've got both of them, I pop into the reporting page. The PI of the MCA is here, 1.64. PI of the umbilical artery, 0.97. So 1.64 divided by 0.97 is clearly greater than 1. So we move forward, and that's about as easy as it is.
Yeah.
It usually shows pretty much end changes, and so by that time the baby's, you can see the baby's not well. And a lot of changes happen before the Ductus does, but
Do you do them both standard in your third trimester, always MCA and umbilical?
yeah,
Because
because
24 weeks? Like
every
OT
time,
or-
beyond 24 weeks,
So 22,
not really 22. I guess if they're coming for a growth scan at 22, it's more about structure. I think there'd be other things that are the reason for that. I don't know. It's just Dopplers don't really.
I just noticed a lot of the charts don't mean much until 24.
Yeah,
they don't necessarily kick in.
Yeah.
Yeah.
So that's our standard. We do the MCA PI, we do the umbilical artery PI, we do the CPR ratio. We very, very rarely do the ductus venosus.
Mm-hmm.
Although I was down at Gold Coast University helping Andrea, down there. But they do it routinely.
Mm-hmm.
They're a tertiary centre there at the hospital, and they just do it on all of their babies. When you're doing it on a nuchal, on a 12 or 13 week baby, it's so easy because everything's so tiny. You get them in the sagittal view, you pop your colour on, and you can see it coming up from the umbilical vein. As soon as it sort of hits the next vessel, which is like the IVC, that's where you sample it, and you can rarely miss it. But in the growth, it can be quite difficult to pick, and there are some babies that don't actually have a ductus venosus, so you can be looking. So basically, if I was to do one here, I'd get your abdominal circumference plane, and ductus venosus is a tiny, like we just said, tiny little vessel that comes off that. It just comes straight off, but it aliases. So sometimes, and that's the key to picking it up. It's just this tiny little one through here, and if you can't pick it up and you're struggling with it, you can always drop your PRF. And then it's a very tricky little. And ductus has a really, you can't hear it very well, but has a really unique sound to it. And you know when you're on it. Like I'm getting a bit of noise from contamination from the other little vessel there. You've got the loop of the umbilical vein.
Yeah, it comes off.
Curling.
That.
It's pretty much just comes off coming towards the stomach.
Yeah.
It's just
And
there.
dumps
See that little one?
into the-
See that little one that's sort of aliasing right there?
And are you moving south, like down to the pelvis from the arch view? Or up?
I am moving higher. So
Oh,
there's
yeah, 'cause
stomach.
you're going to
Oh, no,
the-
sorry. I'm looking at yeah.
That makes
No,
sense. Yeah, of course you go up.
Yeah. So stomach. And then it's a bit too messy, sorry. Just increasing PRF now. So stomach there. that's going towards the head. It's just tiny under that. See that there? That is it. It's like a tiny
colour
little.
gain up a bit.
The colour gain up.
Yeah.
Yeah,
So
it's
is
just
it the teeny thing?
Yeah, it's tiny.
Okay.
Can you ever really see it in coronal?
Yeah, coronal is the best. There, see it? You can't even, like, it's not even look like a vessel, it just looks like mess.
That's it.
Yes, it's not the greatest.
So the
'cause I'm
A
picking
wave
up-
is where it dips right down.
Yeah, so there's, this one's the A wave.
Yeah.
As long as that is positive
Yeah.
above the baseline, that's all you've really got to
Yeah.
look for. Babies with Downs, they often have abnormal A wave. It's more
So-
absent, it drops right down to the baseline
And sometimes below.
and sometimes below, yeah.
So would edema be a thing, like at nuchal, if we see an edematous nuchal, we'll often do ductus?
Well, yeah, because the edema, because of your cardiac output,
Yeah.
you know, you get edema because your cardiac failure or cardiac output's not optimal.
Yeah.
So if that's pretty much just reflective of the fact that the baby has abnormal cardiac, yeah,
Okay.
because most Downsies do, you
Mm.
know, they've got something going on. But yeah, it's not, I don't find ductus very useful in
Mm.
growth. So you come from umbilical cord insertion, these are the little vessels coming in, and you can watch the vein come in.
When it's horizontal,
Yeah, it doesn't
that Doppler signal's going to come in through both channels, forward and revert.
So we don't have to do any measurements on the ductus
Not so
venosus
much, it's more the
It's
shape.
just to have a look
Yes,
at
there's
the-
no
the
PI,
waveform.
RI.
With baseline down so you can see the whole waveform. If you can't see it, increase your PRF. Waveform looks nice and even. Maximum velocity is around 133, so that's fine. But even by increasing the PRF, you can still see it aliases. It lights up like a Christmas tree. And then, so that was just midline out to the left, laterally, swinging out. And the right one, just there. So it has helped to use that different probe. There it is. And if for some reason you've got a bunch of noise and you can't get a nice trace, you can just do the manual trace yourself. Again, I just do one.
As you grow a placenta, your spiral arteries are going to enlarge,
Yeah.
and the vascular bed, the distal vascular bed, which is the placenta, is like a big sponge.
Low resistance.
So because there's so many new vessels growing, the resistance will drop. And so instead of the diastolic flow looking so close to the zero line,
Yeah.
it's going to elevate and look more and more like your ICA to your brain.
You can go transverse and you'll see them pop up either side, which is not what they say to do, but you can like pick them up. And if you're not picking them up again, drop your PRF and just see how lucky you go. You can tell you got it because the alias is it's really pretty. Generally, the velocity of the uterine artery is 60 centimetres per second and above. When you've got a patient who's come in at high risk for preeclampsia on the screening and you get them onto that aspirin, up to 80% of the risk associated with preeclampsia can be reduced by just getting onto that aspirin before 16 weeks. So if we've got a patient that we've screened as high risk and then the doctors put them on aspirin, those, even though we noted or flagged her as a high risk preeclampsia, it rarely happens. Like, we don't see it very often. And then, of course, if you've got a patient coming to you with preeclampsia in the third trimester, generally they go to the hospital rather than where I come. So it's not something that we see a lot.
See, we'll get one referral a year that'll say, plus Dopplers for preeclampsia.
Yeah.
And that's when everyone panics and goes,
Yeah.
what do I do?
What do I do? What do I do?
So if we get a third trimester request and they've got preeclampsia, then just do PI.
Yeah,
check.
and also
it should
do,
have no notch, yeah.
yeah, and also do the blood pressure of the patient as a record of what that was when you're doing the baby, I guess. I don't know.